hotline session today, Professor Steffen from Germany presented results from a large randomized open-label TOMAHAWK trial which undertook to provide a definitive position on the use of early angiography in patients with shockable or non-shockable rhythm. The trial randomized 554 patients with return of spontaneous circulation after out-of-hospital cardiac arrest with no obvious extracardiac origin of cardiac arrest and no ST segment elevation or left bundle branch block on post-resuscitation electrocardiogram to either immediate coronary angiography or initial intensive care unit assessment with delayed or selective angiography in a 1:1 ratio. The primary endpoint was all-cause mortality at 30 days. Immediate coronary angiography did not reduce all-cause mortality with a 30-day rate of 54% compared with a 46% for delayed or selective angiography with a hazard ratio of 1.28. There were no differences in the primary endpoint between the different approaches in any pre-specified subgroups, including patients with shockable versus non-shockable rhythm. The composite secondary endpoint of all-cause death or severe neurological deficit at 30 days occurred more frequently in the immediate angiography group compared with the delayed or selective group with a relative risk of 1.16. There were no differences between immediate and delayed or selective angiography in other secondary endpoints such as length of ICU stay, peak troponin release or myocardial infarction, or in safety endpoints including moderate or severe bleeding, stroke and acute renal failure requiring renal replacement therapy. COACT was restricted to patients with shockable rhythm and TOMAHAWK trial extended the findings to patients with non-shockable rhythm, but both trials showed that early angiography was not superior to a delayed or selective approach. Thank you.